A warm welcome to the Congress coverage from ESMO, the European Society of Medical Oncology Congress, which just took place in Barcelona. My name is Alexandra von Korff, and together with Professor Thill, I attended this congress where we gathered interesting insights on the topic of early breast cancer that we would like to discuss.
Now? Yes, Alex, we were there with probably over 40,000 people and have always high-fived in passing, just because everyone was, of course, on a data hunt, and we would like to share with you the results we gathered on early breast cancer. There are other takes on the topic. This take is about after you have thoroughly memorized the disclaimer and have seen my disclosures, my conflicts of interest. This take is specifically about patients with hormone receptor positive, HER2 negative cancer, and certainly a piece of work that, let's say, is more relevant than ever. It is a work which was presented by the French. It always makes one a bit envious because their databases exist which in Germany, due to data protection laws, do not exist or could not be evaluated. Data that have been supported regarding the evaluation by the Federal Ministry of Health with the idea what happens when an anti-hormone therapy is given continuously, as we would ideally wish for, or if it is interrupted due to the potential side effects involved, what impact does that have? And one can say, yes, we of course know a therapy that is not given is simply not given, and of course it also has no effect. So it is very important, therefore, for all those with early hormone receptor positive breast cancer, especially for younger patients. Why do I say this? Because it is actually about younger female patients who then really need to be highlighted in the study accordingly. Younger means here, first of all, under 70. That's already a compliment for all those who are over 60, that you still count as young. But there are 120,000 patients from the health system, and that is the really beautiful thing about the question of adherence or the compliance with what we prescribe as anti-hormone therapy. And the endpoint here was disease-free survival, which is the absence of the disease over 5 years. What the authors have done always has to be classified somehow, otherwise it gets confusing. Groups are formed to get a bit more categorization, and there was a group therapy adherence with a therapy break included, meaning within the therapy of 1 month or less. I have to be honest at this point, I recommend this to my patients as well. I made a call from the car yesterday, and then the patient said, I just have so much joint pain and I don't know where it's coming from. My hip hurts, my tailbone hurts, and is that something related to the therapy? Now, this is the case for 30% of patients where symptoms that were previously somewhat manageable are unmasked and then do not have much to do with the therapy. There, I also say, why not take a month off? That's why it's quite exciting here, 1 month or 3 months for the second group, or a therapy break of up to 6 months. Now these curves are coming back, which we either love or don't, but which certainly very clearly and distinctly say. And then we all have such a color code, as you can see, it is pink to dark brown. And the curve that is the lowest of all curves, that is always the curve of people who currently have the worst disease-free survival, and unfortunately, those are the ones sorted into groups. Those are the patients who are very young. So here it states 18 to 34, so I would just say under 35 years old. And indeed, we can see here that there exists quite a big diversification, meaning gradation from 18 to 34, 35 to 39, and so on. The curves run all different. While on the right side, these are the patients over 50. There, we actually don't see such a big difference. That's why at the beginning we also said that this study focuses on the younger patient and on the younger patient who then has a potentially higher or lower risk. This is not good news for those among you out there who are simply younger, because they then take away, I have a higher risk of relapse. But that is also the case in the conversations we have with them, so that we say you are then more likely a candidate for chemotherapy, you are a candidate for a more aggressive therapy, because we know that the corresponding risk constellation exists. Well, these really are no good news, but now we will talk about the anti-hormonal therapy, and there one really must say that here you can see now the disease-free survival of those individuals who have received hormone receptor negative findings. And we see that there is no difference, meaning that the shortened disease-free survival does not apply here to young patients with hormone receptor negative breast cancer, especially when it comes to therapy adherence, because that is naturally a situation where chemotherapy has been administered and so on, and no maintenance therapy was conducted. Therefore, no differences were observed here. A significant difference in hormone receptor positive was observed, but no difference regarding age groups in the study, in a hormone receptor negative condition. One could also say indeed that this is simply not different based on age. It is generally a prognosis that is both good or bad, but indeed independent of age, specifically in hormone receptor negative patients. And now it gets interesting because we are moving away from the hormone receptor negative patients again to hormone receptor positive, because these are the patients who receive anti-hormone therapy. We remembered the hormone receptor negative patient, she has a good or bad prognosis independent of age. Hormone receptor positive is dependent on age, especially with a poorer prognosis for the younger patient. As I said, no good news, and here one simply looks at how very crucial adherence to therapy still is for the prognosis, and one must certainly say that for young patients this might also be somehow the explanation for the poorer prognosis, that the patients simply show poorer adherence to therapy. Well, I don't know about you, I don't know how you are doing, Alex, but I don't currently have the impression that my younger patients say, I no longer need the therapy. Perhaps the younger patients are then naturally triggered in some other way. We also said it is very important to point out again in the study, keyword pregnancy. There is the positive study that was presented 1.5 years ago, indeed indicating that a pregnancy indeed does not have a negative effect on survival, that after 2 years anti-hormone therapy, it is indeed possible to take a break from it, and after pregnancy, re-enter. We do not want to diminish it or portray that negatively at all, because this study exists as well. But of course, this is a delicate field and it must be individually decided, for whom do I stop the anti-hormone therapy, for whom do I not continue with it, and who actually wants to become pregnant. I must honestly say I have seen very little patients in my life who had this need, but it does indeed exist. Here we can only say, because we don't have more data on this, which is always what we receive from the evaluations, that in general younger patients tend to have a poorer treatment adherence. And in addition, that we can actually also see those differences in terms of these different types of breaks. Look, here on the left side you can see a break that lasts for 1 month, one of 3 months, and another one of approximately 6 months. We see that persistence here, meaning adherence to therapy, and it concerns always over 5 years, is simply worse for the patients. These are not survival curves. Here, these are just curves showing how patients adhere to therapy. You can simply see that the younger patients tend to pause more frequently and for shorter periods, and typically in general, the older patients are then a bit more adherent to therapy. This simply shows us how is the situation. We once had data from the USA on therapy adherence. There you lose approximately 40% within the 5 years. We once had data from Germany that was presented by AOK. Last year, 40% was indeed also lost from the Cancer Congress. This is a topic, and therefore we have already pointed out in another text how important it is to motivate them to stay with the therapy.
I mean, that certainly also makes a difference in the whole life situation and everything, whether I am dealing with the side effects when I am 25 or when I am 65, how I tolerate it, how the side effects are. My quality of life, that has a completely different significance. So, like you said, pregnancies too.
Yes, and we have also already talked about the ovarian function suppression, that is ovarian function suppression with an injection. Those are different side effects. Here it doesn't make clear what they really received. This is about anti-hormone therapy, treatment adherence, and of course with the young patients, they naturally also have more side effects, no question. I mean, if I induce menopause in someone at 35, it is different than in someone at 70 or now under 70 or with 60 in the study. So no question. But what is shown here is the knowledge we already have about it is being confirmed again, is being revisited, broken down into individual age groups, and this of course also tells us how important it is to maintain the patients consistently on their prescribed therapy. Because we simply observe that the overall patient survival rate suffers from it and that the patients simply experience a disease relapse. We have it here. Again, because everything is so clear here in this forest plot, it's just like that. That is then interesting for me and for you, what we have summarized, that we actually have to work with data here that is, in a way, unfortunate, but they simply have to be stated that someone who is particularly young has a 5-year survival rate if they are not adherent to therapy, which then simply results in a 6% reduction. And with the patients who are older, there is a difference of 1.2%, so less. So one must indeed say that adherence to therapy really pays off. Therefore, one can just say, take it consistently as well as possible. Alex has already mentioned it, side effects. And I also said there are patients who say, I just simply won't do it just because it existentially threatened in the job, in the family, in the relationship. And that is then actually a decision-making process that must be pursued together. But at least we take away that we need to make even greater efforts to see patients and address problems, to address sleep disturbances related to anti-hormone therapy, sometimes using a depot melatonin, not the stuff. What is available in the pharmacy rather than the drugstore. That we work with acupuncture against joint complaints, that we motivate sports, also a topic that we had here in the reporting. And that we try to reduce side effects as much as possible by trying to actually offer the services that we currently have available.
That definitely sounds like a good plan. And I absolutely believe when I carefully examine the numbers, it is somehow nice to see we have a number, we know exactly how much worse my survival risk is. And on that basis, I can then individually decide. Then I say, okay, 6%, that might be a lot for one person. And someone else says, I am indeed hungry. I really have bone pain. I have hot flashes. I feel so bad. It's not worth it to me. This way, everyone can then decide for themselves together with the practitioner, make the decision.
Absolutely. And together with the healthcare provider, I believe that is the key word, to emphasize once again that we simply must take side effects seriously. We must not say, that's just the way it is. And the local colleague should not say, you have to deal with it now, but rather one must actually reach people. And in our beautiful healthcare system where conversational medicine does not, paying for it is of course always a challenge, but one should simply adhere to it. And again, anti-hormone therapy is now more relevant than ever. In addition, there is still so much more. Coming towards us, there will come a combination of anti-hormone therapy and targeted therapy. It's actually a very important topic for us as well. Yes, indeed, exactly. But what I find nice
is, and you can certainly bring this up with your doctor if you mention acupuncture and melatonin dip, and what you can do is a little bit more of a challenge and say, okay, do I have to live with it or can we still do something about it? And maybe then we can also find solutions together.
Yes, this is important. That's why we do a format like this. And so that you out there can also, as you know, nicely challenge your doctor. And the data that will come now is also challenging for us because we do not yet know exactly how we will conduct this amount of treatments. This now is related to the data from a study of the NATALEE study, which also deals with hormone receptor positive early breast cancer. It is a study which has been in the running for a bit longer. Here again is the relevance, as already just mentioned, regarding the data we have from the last 1.5 years. And here it was about the comprehensive 4-year evaluation of over 5,000 patients who not only received an anti-hormone therapy, an aromatase inhibitor plus or minus, a GnRH analog, meaning the ovarian function suppression, depending on the age, but also the combination with eboziclib, a CDK4/6 inhibitor that has long been approved for use in metastatic situations, and that is very, very effective and certainly marks a milestone within the group of CDK4/6 inhibitors. Regarding breast cancer therapy, the primary endpoint here was the disease-free survival, and then, once again, the two groups to make it clear, so aromatase plus minus GnRH analog, once just alone and then once in combination with the ribociclib. And then, when you are looking at the older data, we are moving from evaluations at 2 years, 3 years, now we are at 4 years, always with the question, is this therapy? And we are now talking about 3 years of ribociclib plus an anti-hormone therapy. Is that actually something that can potentially and significantly affect survival positively? We know that is already the case. It was a bit, not so much. Yes, 2.9%. That was the last evaluation for disease-free survival. But is that now something that actually continues? And we can see it here, and you already mentioned it, regarding the side effects, how many patients discontinue. We have 62% here of the patients who, and these are now all patients who are no longer being treated. So one can say how many have completed it, and that were 62%. And the reason is, of course, always the side effect. And the reason here too is that there are different side effects. And there are some that can be quite well managed through dose reductions, some are not. The increase in liver values is such a topic, but that is also the reason why I initially mentioned that it is quite challenging to deal with this new and innovative form of therapy and supervising this therapy. Otherwise, you have issued a prescription for an aromatase inhibitor. We have just said it's important to control that, but you didn't have to perform a weekly blood count check weekly and also do an ECG first, then do another ECG, and then also implement a dose reduction. You really have to work properly with this therapy to then adjust the dosage. The goal is to maintain the therapy for 3 years. So you need to somehow find the right dosage in a way that it is not a problem for the patient to continue to this therapy. And if I really have to come to the practice
every week, then of course it is also a huge effort for me. That is not only just
a huge effort for you, it's also a huge effort for us. And that's why I don't see it as so simple. And for you who are listening out there now, when you then ask, can I have an appointment? It becomes harder with scheduling appointments, then the waiting times get longer, then the dissatisfaction increases. The hospitalization, because you are in your center, is not done by a private gynecologist. Instead, you go into your therapy center, and we have estimated that for every 100 patients with this treatment, we have 1,700 more contacts. Wow, to mention such a dimension, and somehow you have to manage that. Regardless of that, one must say undoubtedly great data. Let's get back to the study, because here we still see a significant advantage through ribociclib and an anti-hormone therapy. Yes, and even there, the curves are only slightly apart. But if you think about where we started 30 years ago, then we simply took it step by step. And here we have 5%. 5% advantage that the disease absolute advantage. A relative advantage of 30% that the disease does not recur. And it doesn't matter at all.
You just said anti-hormone therapy, but you meant aromatase inhibitors.
Aromatase inhibitors in this case, yes, definitely. Plus ribociclib, and this is, in fact, regardless of which stage you are in, regardless of whether the lymph node status is negative or positive, whether the patients are under 40 or over 40, we always have this 5% advantage. And perhaps what should be also said about the study is that patients could participate who did not have lymph node metastases, but they then had to qualify with certain other criteria, of which we say the risk is simply higher. Now, I don't want to go into detail, that would be overwhelming, but our job is to say that if we carry out this treatment on a lymph node negative patient, then there still needs to be something at stake. It is about having a risk in order to then reduce it. If you have no risk of relapse, you don't need therapy now either. It would indeed be an overtreatment. And if you look, how is it then perhaps with overall survival? In another take on triple-negative carcinoma, we talked about the overall survival, and one can certainly imagine that this will continue in this study as well, because the results are improving year after year and the curves continue to diverge. And we see that this 3-year therapy maintains this advantage even in the long term. We call this carryover effect in German and English. And what you can see here now is that approximately 70 patients have had fewer metastases. These are not good news either, but we know that the disease returns. And here you can see, based on the different levels of these bars, that especially distant metastases were reduced by the therapy, and then one can postulate that this could eventually lead to an overall survival benefit. At the moment, the whole thing is not mature enough. Here you can see the side effects, and there you can see what this therapy does. It causes neutropenia. I still remember when we filled the study with patients and recruited them, I told the patients 88% of them received chemotherapy. These patients in the study were almost all treated with chemotherapy. And then the patients came and said, so now the hair is slowly growing back and all these blood count checks, I am really fed up with it. And then I said, I have a great idea. I am now starting a therapy where these blood count checks will begin again. And then, of course, that was something that no one wanted to hear. And we see that this rate of neutropenia, so the decrease in white blood cells, occurs in 60% of cases, with some variation. But that's why you have to look again. And of course, that's 3 years then, and that is indeed a long time. This is not a chemotherapy lasting 4 to 6 months, but that is 3 years, and you really have to make sure to stay on track. And as we discussed earlier, we already talked about therapy adherence, and it will be even more challenging there to demand treatment adherence. How we are supposed to manage this with nursing staff that do not exist, I don't know. Maybe we'll do it with AI-based avatars that will be somehow available. to provide answers for questions. I don't know exactly. That is certainly a topic. So these are the side effects here. I have already mentioned the liver. That is certainly a little bit more challenging, but otherwise it's nothing that is really challenging. Well, we come to the conclusion. Again, very briefly, this is a therapy was approved in America just the day before yesterday by the FDA, which is the American Health Authority, so the therapy is very recent. And for those who watch this at a later time, we are now recording on September 20th. So that was the case 3 days ago. This means we will probably approve that in half a year, in Germany as well. And then it becomes reality. And then you have to say, it will become a standard therapy because it simply shows such an effect. And we have currently a CDK4/6 inhibitor that we have approved, which is Agaplesion, which is already frequently prescribed. But this is only possible for patients who have all positive lymph nodes. And we now have another patient group here that indeed has a high risk of infiltration without having lymph nodes. And one must say that will simply expand the portfolio. We will treat a broader patient population. And then the resources also come into play there, which we somehow have to manage, but that will be, for us, just like the side effects for you, a challenge.
Yes, those are indeed very, very exciting findings. And at the same time, I naturally have in the back of my mind, okay, what about all the side effects now? We're not talking about a therapy that you can just do for 3-4 months. And the other issue is the lack of staff, making it possible to even implement this. Because somehow breast centers are supposed to be closed, things are to be merged, there is already no staff, and I wonder how that is supposed to work, but you have also said that it would be a significant challenge. But if it naturally brings this added value, then it is of course nice to see that you have this option and can also benefit from the positive effects of the CDK4/6 inhibitor in the non-metastatic area. That's great. So again, in essence, a basis that we present here for making joint decisions together.
Yes, flawless, great data, great that this continues, great that survival is always improving, of course always at the cost of side effects. But we are not talking about every patient here, rather about a specific patient, which inherently carries a higher risk, and that is then assessed. This assessment is also becoming more diversified. We are not standing still there, and then one will hopefully be able to treat even more individually. But clearly those who have a risk of recurrence will be offered a therapy, and then one must see if it is tolerated or not. But clearly something needs to happen now. We cannot just letting hospitals die completely unregulated and not creating new capacities. We see that with us, we have a large center, and the waiting times are getting longer and the complaint rates are increasing. And the dissatisfaction on the part of the patients, of course, also on our side is also increasing. And that is, of course, generally a serious problem. Let's see what the hospital structure reform with the service groups and also with the different levels will contribute. But fortunately, that is not our topic here.
Exactly, that is a different topic, but I always say we are not the Deutsche Bahn or something like that. It's about survival and human lives and not about luxury problems. Thank you very, very much for taking the time today to discuss these studies from the European Society of Medical Oncology so thoroughly with us, with me, and explaining it so nicely and clearly for our viewers. Thank you for that. You're very welcome. Thank you very much.